it's Kate, it's summer, and welcome to an Ask Me Anything episode. Please use your question box to add questions today. I'd love to make this interactive. I am going to start with an update because I know that when I go on holidays, I come back to the office and think, oh gosh, what have I missed since I was on holidays? So I wanted to share with you as a starting point what has been going on this summer and even do a little recap about what was going on this year in privacy. So that's what we're going to do today. Please say hello in the question box so that I know we are live and working and that you're here joining me today. Great, perfect. Okay, so while you were on holidays, what was happening? Let's see. So the first thing that started, and this was really in May, you may have noticed that your inbox got completely filled up with all kinds of requests from all kinds of different businesses with whom you shop or do business online, asking you for permission to continue to communicate with you. And the reason why many of those messages got sent to you was because of the GDPR. What is it? What does it apply to you in healthcare? So it stands for the General Data Protection Regulation. It came into force in May of this year, 2018, and it really gives protections for citizens of the European Union. Does it apply to healthcare? Mostly, no. Mostly, you don't need to know anything about it, except that you need to know how to answer a question when somebody comes up to you and says, are we GDPR compliant? Unless you are doing business with citizens of the European Union, and for most of the people and organizations with whom I work, you're not, then you really don't have to do anything. So it's really if you're selling goods or services or doing business with individuals who are in the European Union. So that's what that is all about. Mostly, you can ignore it. In fact, the Privacy Commissioner in July, the Information and Privacy Commissioner of Ontario, issued a worksheet saying pretty much the same thing. For most of us in Ontario, in healthcare, it's not going to affect us unless you're doing commercial activities working with groups in the European Union. Now, another thing that came out was the report from the Information and Privacy Commissioner. And so that got released in June. How many of you knew there was a new report from the Privacy Commissioner? Click in your box and tell me how many people maybe have read it. Have you read it even? Are you fully up to date on what was in that report? Crickets. Silence. Maybe none of you have read it. No worries. So there are a few of you saying no, you haven't had a chance to look at it yet. So this report was just released in June from the Information and Privacy Commissioner, summarizing the rich history of that office. So there have been 30 years that that office has been in place, and they did a really nice tribute to the work of that office. So I would, as privacy officers, recommend that you have a look at that report. From a health privacy perspective, there are a couple of things of note. And so this was a reflection on the 2017 annual report. So this isn't a 2018 update. It has to do with statistics from 2017. They dealt with over 600 health complaints, so related to health issues and health privacy. They managed most of those at intake. And so I think that's relevant for all of you in a privacy office, because sometimes it's hard to know, you know, is this going to be a really long process? If somebody makes a complaint about our organization to the Privacy Commissioner's office, is this going to take up months and years? Generally speaking, no. They are able to resolve many issues at intake. So that is a good news story. It also makes sense because most issues can be resolved when, an explanation is issued. So that bore out. The Privacy Commissioner issued 26 new decisions in 2017. So again, big volume, lots of education. As a reminder for all of you, I do have the free resource where I summarize all of the privacy decisions. Has anybody, let me know on the comments if you've seen or read it. If you need any help finding it, it is on my resources page on my website. So you can check that out there. Okay, so that is what's going on. A couple of other just general comments about what the Privacy Commissioner observed last year, and that was that the vast majority of concerns and complaints that came to the Privacy Commissioner's attention had to do with lost or misdirected personal health information. So that's the vast majority. So that would include things like lost USB keys, unencrypted laptops, issues of misdirected faxes. So that's the vast majority. That makes sense. 24% of the complaints had to do with snooping, right? So when you're looking at your efforts about how you're going to train your team, train them on lost and misdirected information and devices, train them on snooping, and then there was 18% general unauthorized collection, use, and disclosure. Thank you. There was a comment that this person uses the summary of the decisions all the time. So glad that you find it helpful. By the way, here's another update. I have now updated that resource so that when you look at it and click on it, you can actually open up each decision. So I've made it now that you can access the actual decision itself just through a click. And I also organized it and labeled it so that you know the type of organization for whom that order or that decision relates. So I've listed now primary care clinics, hospitals, community health centers. There have been some decisions for public health and other kinds of groups. So that summary now will help you identify the kinds of decisions you might want to share with your teams in your privacy training to bring the storytelling, bring privacy to life for your team. Now, I am not getting so many questions in my Ask Me Anything webinar, so remember to start typing in your questions for me to start to answer at the end of my update, or you can raise your hand and I will open the line and you can speak. But it's going to be a very short webinar if we don't have any questions. Okay. In the Privacy Commissioner's report, he also identified that there were 2 prosecutions last year. So we've had now 5, but there were 2 new ones in 2017. So that was the social worker in a family health team who was fined a total of $25,000 for looking at the records. She was prosecuted for 5, but had looked at 139 records. And a new decision last year of an admin support clerk in an emerge department in a hospital who was fined $10,000. So a discussion of those cases you can find in the Privacy Commissioner's 30-year report. Here's an update for you that you might not think about from the Privacy Office, but this is absolutely relevant for you to know, that in July of this year, nurse practitioners now have mandatory duties to report impairments that could impact an individual's ability to drive. So that used to be physicians and I think it was pharmacists who had to make those reports, but now it's also nurse practitioners. So this is something for any of you who have team members who are nurse practitioners. Now there is an override relating to an obligation to report to the Ministry of Transportation under the Highway Traffic Act if their patient, their client, is at risk of harm for driving. So impaired drivers, they have a condition that would negatively impact their ability to drive. So that came into effect on July 1st. Lots of resources for nurse practitioners about how to make those reports. There are forms that are available on this College of Nurses website and other resources. I have a link on my blog about that update, so if that is relevant for any of you. Okay, another change in legislation that that I want to highlight for you has to do with the Child, Youth and Families Services Act. So we have had child protection legislation for decades in Ontario. You may not think about it so much in the privacy office, but it does affect you, your teams, in lots of different ways. So I wanted to just give you a heads up that in April of this year, the legislation was updated. The age of protection for children has been updated to now include 16 and 17-year-olds. So children in need of protection are up to the age of 18. So 18 less a day. So 16 and 17-year-olds, if there is a child who is being abused or at risk of abuse, mental abuse, physical abuse, sexual abuse, now that is reportable to Children's Aid. So it's extended the reporting age to 16 and 17-year-olds. Now in 2020, this legislation will now also create an entire privacy regime for Children's Aid societies. So in 2020, anybody who has personal information that is held by a Children's Aid Society will have a right of access to it. Very, very similar regime that we have in healthcare will now apply to Children's Aid Societies. Now, interesting tip for any of you who are privacy officers, imagine all of those agencies are going to need privacy officers. So there's going to be a real opportunity for people in privacy officer roles to have new opportunities in the children's aid sector. So that's happening. So the questions are starting to come in. Good for you. Keep going. Please keep typing, or you can raise your hand and I will answer you at the end of this update. Okay. Now, this update really relates to April, but you may remember that it continues in the news, that there was a huge scandal involving Facebook and Cambridge Analytica about Facebook using personal information and selling it to other companies that then took that information and were targeting ads and were doing influence campaigns to impact elections. So this has been in the news. It's, it's a kind of a constant message that we all hear. Now, the reason I want to raise this for you from a privacy perspective is that I think we are starting to really feel in healthcare the impact of these kinds of scandals in our sector. And by that I mean people are, there have been a sector or a segment of our patient population, our client population, that have been leery about electronic health records or electronic health information. And when we get scandals like this, it really undermines the trust in the healthcare system, because we are now coming forward and saying, yes, trust us, give us your email address, share information with us, and we're, embarking on this amazing electronic health information record system. And we may be met with blank eyes, concerned looks, people saying that they want to withdraw, and also people not choosing to participate in research protocols. So I think it's really important for all of you in privacy offices to be thinking about how do we reinstate privacy cultures of safety and reassurance, because what we are being bombarded with in the messaging on the news, online, is that electronic is bad. And any information that you share with anybody at any time can come back and bite you. And I think, again, I just want you to start to think about, maybe you can make even some comments about this topic. Have you experienced any kind of pushback or negative impact from these kinds of stories that are in the general public? So another update, this just happened in June, and I don't know if any of you had heard about this particular case, so let me know if you did, but there was a home medical services company that got hacked. So this is the Care Partners case. They issued a press release so a couple of you have heard about it. It's a huge deal. And so they issued a press release in June, Care Partners with the Ontario, with the local health integration networks, because Care Partners is a provider to LHINs. And they were hacked, so they had a cyber attack, and tens of thousands of health records were held ransom, and the perpetrators actually got through to the records. So a very significant cyber attack or ransomware attack that happened in Ontario. So you will remember last year in May, there was the international WannaCry virus that hit the UK in particular, healthcare environment in UK, but other sectors. That virus also hit in Ontario, and there was a hospital, at least one hospital hit by that virus. But you will remember, as privacy officers, there are lots of resources that our Information and Privacy Commissioner has issued on the topic of ransomware, very practical advice about things to put in place. But that was a new big case that you should know about. And you know what? I would actually take that case and share it with your team, explaining that, you know, this is a thing, this is something that really honestly happens. It's a very powerful story that you can use to explain to your team members how to ensure that they are only opening emails or attachments in emails when they know they can rely on it. And also just to remind your IT service providers, your security IT service providers, to make sure that they are keeping up with all of the security patches for your system. So we do have now 73 decisions that have come out from the Privacy Commissioner's Office. So again, those have all been summarized for you, and my summary has now been updated to just allow you to click and open. If you want to read more about any of those decisions, you can click and read the actual decision itself. In 2017, the Commissioner issued 26 decisions. In 2018, there have been 8 new ones. So I just wanted to give you a very quick highlight of what each of those decisions related to, in case you haven't been keeping up with it. So here's the way in which I organize the decisions, and this is maybe helpful for some of you. Take a picture of this, but when you are doing your privacy training, what are the categories that you need to be thinking about to educate your team members on? These 9 topics might be really helpful. The topic of collection really only had to do with the Ministry of Health collecting OHIP numbers, so that might not be something that your team needs to know much about. So we'll start with decision 65. So this really reinforced previous decisions of the IPC about what counts as a reasonable search. So this relates to when you get an access request, when one of your patients or your clients asks for access to their record and they think you should have more information. You've given them a copy. They say, well, we think there should be more information. One of the things on which you can be criticized is whether you did a reasonable search. So this is a decision dealing with the reasonable search test. The Commissioner said, yes, the hospital did do a reasonable search. I found this decision is just very much in keeping with the prior decisions on this topic. So that was a hospital. Okay, so then we had a community health center, and they had a correction request. This decision, again, very similar to the decisions we've seen before about correction requests. Again, as a privacy officer, you want to know that the vast majority of these 73 decisions of the Privacy Commissioner have to do with access requests and corrections. And so this is just yet another example of a correction request, and the Commissioner did uphold the Community Health Center's decision not to make the correction. here's another one. So this one affected a local health integration network. This had to do with resident assessment instrument assessments, so the RAI, and the commissioner upheld the decision of the LIN. So again, no need to correct. Now, if you're going to read a case this year, read Decision 68. So this one I call my soap opera case because it is highly dramatic. And I think this one is really important for you to read as a privacy officer because there are some tips for your team to really understand. So I'm not going to get into the whole backstory here. You can read the decision itself or read the summary. But basically, this involved a physician who used to be part of a team. So imagine there was a physician who worked with you, with your organization. That physician no longer works with you, but his wife was a patient of yours. He and his wife have now split. He comes back to the team, so a former colleague who knows your team members, knows your staff, and says, hey, can you help me out? You know, Kate, I need a copy of my wife's records. And she said it's fine. Also, and I know her doctor, and he said it's fine too. And the receptionist helped this former colleague get access to his wife's information. Lots of other details. He tried to get more information from the hospital. He got some information from a pharmacy. So very complex situation. He felt that he was justified in searching this information out because they were involved in a custody battle over their children. So some righteousness in the pursuit of her information. So this is a really important decision for you to know. And again, the takeaways for you to train your team about are, you know, when people come and they ask you something that makes you feel uncomfortable, do not, you know, helpfulness is one of the characteristics we really look for in healthcare. But in these kinds of situations, you want to slow down the process. When a former colleague comes and says, hey, can you just help me with the EMR, the EHR? Can you help me get some records? Don't do it immediately. Find out if this person was truly entitled to the information, because in this case, he was not. So big case. That is something I would highly recommend you look at if you haven't looked at it yet. Now, this was another case that's really important for you. So this involved a hospital, and there was a former employee. So that person had been employed in the research team and was a registered health professional who had been in that team. And that person, before their employment ended, had taken home records as part. So it was allowed for them to be working on those records, but they should never have taken them home. And so after the employment was terminated, they knew that this person had signed out records, and when they asked the person, where are they, they were gone. So one of the things that came of this case was there was no evidence of theft. This wasn't malicious stealing of information, but the records are gone. So the privacy commissioner was concerned about whether the hospital had taken adequate steps to protect the information it held, and found that it had not taken those adequate steps, but then the hospital agreed to put in place some procedures to prevent this from happening again. So there's another case for you as a privacy officer to read for sure. And then there was a case, oh, I've missed one. It's Decision 70. So the Decision 70 had to do with a long-term care home, and an employee took information home and lost the records on the way home. Again, that's a good one for you to read because it really has to do with your team members who are transporting health records. And in that case, the privacy commissioner said that the long-term care home had not done enough to protect the health records. So it's really about talking to the team about when you're taking information off-site, what to do. So then we're on to 71. So this is another correction request, very similar to the other correction request, although in this one, the commissioner went into the definition of what is an opinion. And I pause here because one of the defenses for making a correction is if your clinical team members make a note in a chart and somebody doesn't like what they wrote, but the team member says, well, that was my clinical opinion. That's my professional opinion that I made in good faith. So in this decision, the privacy commissioner examined what is an opinion and or an observation, and so went into the details of that, found that this was professional opinion, and also talked about a presumption of good faith. So if one of the patients is going to allege that your clinician was acting in bad faith, they have the burden of proof to actually show bad faith. We don't presume that somebody who's written in a health record was nefarious or engaged in bad activity. We presume good faith. One of the last ones, so decision 72, another correction request. The privacy commissioner in this case said there were no grounds to review. And in this case, the patient really had not set out enough information for the medical clinic to make a correction request. So very similar. And now this one, the most recent decision, is also something you should read. This one is an access request. And I think this could have a ripple effect of concern, especially for your board. So in this case, a family member asked for access to records of communication between the hospital and some external parties about a relative who had been a patient, and wanted to have information about the internal reviews and actions taken by the hospital in response to complaints. So now all of your spidey senses should be going off, right? So this family had concerns about the care they received in the hospital, and then they wanted access to the hospital's response to those complaints. So the hospital did issue and provide access to records, but they denied access to some categories of records, including correspondence with HEROC. So that's the Health Insurance Reciprocal of Canada. So for those of you who aren't subscribers to HEROC, it is an insurance reciprocal. So think about your insurance provider, and if you had correspondence with your insurance provider. And so in this case, the hospital was ordered to provide the requester with access to one record of communication with its insurer. The other ones were covered by other kinds of exemptions. But I found this really interesting because normally we think of communications with HEROC as being in anticipation of litigation and subject to legal privilege, or at least protected under the privacy legislation. So this was a real development in terms of being required to share information with patients or their families about those external communications. So there you go. There's your update about what's been going on this summer for health privacy, and a little bit broader so that you are up to date. But before we get started on the Ask Me Anything portion, I wanted to remind you that there are some upcoming events that I have. We have a privacy officer training, which is starting again on October the 2nd. So the first day is in person, and then there are a series of webinars that I'd love for you to join me, or if you've already participated, just let some other folks know. I'd love to bring them into the community. Advanced privacy officer training. So we had our first version of that in January. I got lots of feedback, and so I've rejigged a bunch of things, and I'm relaunching that in November. So for all of you, because many of the people who registered for this program, you're advanced. You know what you're doing. So this advanced privacy officer training is one day. It's in person, and I've made it super interactive. So now the whole day is interactive, and it basically is, you get a sheet of paper, it's like getting a complaint in, and then you have to figure out, okay, what am I going to do? Who am I going to call? How am I going to act? What is the right path to take? What are the decisions that I have to make? So it's almost like a choose your own adventure privacy training, and I'm really excited about that. So that one is November 13th, and today, I'm pretty sure it's going to launch today. I have a new free privacy officer webinar series. So there are 4 videos designed to help privacy officers feel more confident in what you do. So I will make sure that everybody who registered for this Ask Me Anything webinar gets the link to those videos. So I'm very excited about that. Okay, so now what I want to do now is go through your questions. So if you want to raise your hand or put in your question in the question box, I will get to it. Okay, let me just see if I can make this. I'm going to stop showing this one. Okay, so what we have here is the first question. What is the expectation for consequences in our privacy policy? Do we have to be specific, or can we refer to our progressive discipline process? Did I get the first part of that one? Okay, so if you are the person who asked this question, I need a little bit more information. Hang on, let me just, because I know you have asked. Okay, so in terms of how, like, do you mean, or put up your hand, do you have to specifically say what you're going to do as a disciplinary consequence? Is that what you, is that your question? Yes, excellent. No, you do not. So you absolutely, in your privacy policies, when you're talking about disciplinary consequences, the words you want to include are up to including termination of employment. And if you have physicians or other kinds of independent contractors, you'll include the words termination of contract or termination of relationship. That's not so much about privacy as it is about making sure there is clarity for employment law purposes and contractual purposes of what the consequences will be. I am really leery about putting in zero, you know, like those provisions that say zero tolerance. We take a zero tolerance approach because, so for example, I've had a couple of teams who've had privacy breaches of their staff who were looking at their family members' records. And they said that the family member gave them permission to look at their own record, and that and then when we speak to the family member, they said, yes, I gave my grandmother my permission to look at the record. And you're thinking, I highly doubt that. But maybe that person's been working with you for 30 years. So if you terminate that person's employment on a zero tolerance, you know, practice, that is, you know, probably going to be a pretty significant payout or notice period, etc. So I'm leery about putting in zero tolerance kinds of language. The kinds of things that I'm starting to see now, though, have to do with just culture language in privacy policies, and looking at communicating that some privacy breaches are really systemic issues that require re-education or team information to prevent, as opposed to individual consequence. Another just response to this question, I recently had a health center talking with me about the response in communicating the privacy policies to their group. And some individuals had the impression that if they were, for example, if they used one of the laptops that were issued by their employer, and that laptop, you know, didn't have the right encryption level in it, that they could be personally liable for that. So you do have to be careful about how you're communicating consequences and disciplinary consequences and even legal consequences, because sometimes people get the wrong information and they think that, whoa, like I got issued a laptop by my employer and it was unencrypted and I saved information and now I'm going to be fined and go to jail and, you know, be penalized. So there is nothing in the legislation that requires that you spell out, if this, then this consequence. About 4 years ago, there were some hospitals doing that, and they started to capture what constituted grievous privacy breaches. I think that's somewhat helpful, capturing that information, and maybe just even for yourself. I know that there have been some teams that have talked about what is the continuum of severity of privacy breaches, and how will we bring objectivity to the analysis of how somebody is disciplined. Because without objective criteria, you are always left to, what do we think about this person, right? So if it was a really nice person or a very popular person, they may get, a lower end consequence. And if it's, somebody that people don't like, then you may be left to subjective thoughts and thinking. So thank you. Okay. A physician in our organization keeps receiving errant faxes from the previous organization where they worked. So despite numerous calls to the organization to say not to send the physician this information, they continue to ignore us. Should we call the privacy commissioner about this consistent pattern? Thank you, because I get this kind of question all the time. This kind of scenario also happens if you have clinicians who have similar names to other people who don't work in your team or community, but they happen to have a very similar name or the exact same name. So this happens all the time. One of the things I recommend in these cases initially, and you may have already done this, is putting the complaint in writing as a first step. So say, this has happened, I have collected, and the other thing is be really specific about the number of times it's happened. We are receiving 25 faxes, 25 communications per week errantly. They are supposed to be keeping track now and reporting this as of March 2019 of how many stray faxes they had, or errant faxes, or faxes that went to the wrong place. So if you are putting in writing that you are getting 10, 20, 30, 50, 100,000 of these communications weekly, monthly, annually, that's really challenging for them if and when they have to report and they didn't do so. So put it in writing, be very specific about the number of times it's happening. The next piece is communicate with the privacy officer. So sometimes, and you probably have already done this, is put the complaint in writing to the privacy office as well as their IT department. That doesn't necessarily fix things, but one of the things that's happened for a couple of my teams is that they sent the complaint to the person whose name it is. So I'm getting Kate Dewhirst faxes. I call up Kate Dewhirst, hey, you need to fix this because I shouldn't be getting these faxes anymore. Or, hey, other place where I used to work, please make sure you fix this. But when you contact that person's privacy officer, sometimes that really ignites action and change. Now, if you have had no response, and I'm guessing that is what has happened so far, you've had no response, I do have cases where people have gone to the privacy officer, privacy commissioner to make a complaint. The reason for this is especially if every time you contact them, they sound irritated with you and they're not working with you. I think you might want to give a little bit more space, runway. If they have said, oh my gosh, I'm really sorry, we've been really working on this. I know this is a problem, but we are really trying to fix this for you. Thank you for letting us know again. If they feel like they're in the struggle with you, then I would give them a little bit more space. However, if you notify them, and every single time you notify them, they sound grumpy, irritated, or just like nonplussed about it, then that is a time I would bring that forward to the commissioner. And again, if you have been sending them letters and saying, I got another 10, I have another 15, what are you doing about that? And they're not helping you, then you would say so to the privacy commissioner. Now, there will be consequences, so you do always have to be thinking about your relationships with other organizations and other teams. So that is something you're going to bring to bear in your decision making about how to raise this. But I know, because I talk to all of you, I know it's it's frustrating when you have a repetitive privacy issue, and especially when you are on the receiving end of highly sensitive information. Now, here's a thing, however, to note. Your organization too may be doing the exact same thing to someone else. So lots of teams in primary care, lots of hospitals, lots of long-term care homes are sending faxes to the wrong pharmacy all the time. So just remember that you will want to be being thoughtful and responsive. So you have to, all this advice that I've been giving on this piece about how to try to encourage people to act, all of us, all of you really need to be thinking, are we guilty of this? Are we doing this to the labs? Are we doing this to the pharmacies? Are we doing this to the, agency? We've made a lot of referrals to that agency. I didn't realize that that clinician has moved on. And so just thinking about that, I think that's a really big piece too. So thank you, that was a great one. Okay, so here's so keep on coming. I have a few more ones here. Okay, so this next one is the provincial immunization database uses healthcare numbers as unique identifiers. So we need to collect this information from our clients to ensure that their information is up to date. Some in our agency are concerned that our collection of that information violates privacy since we aren't billing for our services. So I'm guessing this is, okay, so unique identifiers. Are you talking about the OHIP number as your unique identifier? I'll just wait for you to answer. Because it sounded here like you had to collect, yeah, so that's what you were asking. So there are some restrictions about under what circumstances you can collect the OHIP number. I haven't looked at its application with respect to the immunization database. The privacy legislation does talk about the collection of OHIP numbers and under what circumstances you can do that. So it is a flag. This is an issue that you do need to think about, and just contact me after and I can have a look at the legislation with you. But there are certain circumstances when you can collect a health information, so the OHIP, the Ontario Health Insurance Plan number, and then there are times when you're not allowed. So it sounds like you need a unique identifier. I'm just not sure whether the OHIP number is the right one for you, if you otherwise don't need to have it. Okay, so here's another question. How detailed do our destruction records have to be? Oh, okay, so the question here is, how detailed do we have to be in the log that we keep of how we have destroyed health records? Individual clients or program name or year? I don't know. I think that you want to, as far as I know, I don't think you have to keep track of each person's records that you have destroyed. You definitely, I would say definitely you want to keep a log of the destruction of your records by year. So absolutely keep track. We destroyed all records by year. Now, here's another piece in which you have to be specific about the year. What year are you talking about? So the last time the person came in to receive service from you, the date, the first time they came in to see you. So you just want to be clear about, I think what you're measuring is the date of last visit. So the last time that person came to see us or had an interaction with us or lived with us or whatever your services are, it was the date of last contact. So definitely year. Then program, I would say yes. I think you do want to keep track of the programs whose records, and we've deleted those records, but I have not heard that you have to keep track of individual client names unless you have so few that you are serving such a small set of clients that you can keep track of, we destroyed 10 records this year. I think this is all going to be very much specific on the volumes that you're dealing with. Okay. So again, keep those questions coming. So I had a few other ones that had come in that I wanted to share with you. So one of the questions that I get a lot has to do with police, and police coming in and asking for medical information and records. So here's an example, and I want you all to think about what kinds of interactions have you had with the police, and what questions should you be asking when the police ask for copies of your information. So this is one. A patient reported details of a sexual assault to our team and subsequently reported the assault to police. The police had the patient sign a release of information to access the patient victim's records. The patient was motivated and asked the records be released to help with the investigation. We provided notes for the police which pertained to the assault. Our progress notes do not spell out the names of clinicians. It provides initials. The police sent a note through the patient asking for the names of the clinicians. And so the clinicians involved in this particular case were physicians, nurses, and social workers. Do we need a release of information or a subpoena, or can we release the names of those clinicians? So one of the things that I always recommend, anytime you're dealing with a very serious level of allegation, so a sexual assault is always serious, that you just pause and get advice specific to this circumstance, because anytime there is a big issue, risk issue that you're managing, you just want to make sure you're getting the exact right advice. So in this kind of question, there were a couple of key words that came up. Physicians are involved. Anytime physicians are involved, you want to encourage them to get their CMPA, the Canadian Medical Protective Association, advice. Similarly, if you have other kinds of independent contractors, like your nurse practitioners might be independent contractors, your midwives might be independent contractors, others might be dentists, might be independent contractors. If they are affiliated with you but not your team members, you do want to encourage them to be getting their own independent advice in these kinds of cases. So that's always my step number one. When we're talking about police, there are two sections of the Act on which we almost always rely. So does anybody, for bonus points, know what those sections of the legislation are? Type it in your questions box. I'll wait for a second. You know these sections, you know what they are. Crickets. Okay, maybe I am the only one who knows the sections off the top of my head. Okay, so they are section 40, sub 1, and section 43(1)(g). So anytime you have a police issue, we're always looking at those sections of the legislation. So the section 40 sub 1 is that general protection that says, in the event that there is a situation of serious bodily harm, and you could share information with someone in order to reduce or eliminate a significant risk of serious bodily harm, you are allowed to share with anyone. We almost always rely on that provision when we're sharing information with police. So one of the things we're thinking about here is, do we need, so you already have consent in this particular case to share information. But always when dealing with police, we have extra discretion when we're talking about a significant risk of serious bodily harm. Section 43(1)(g) is you can share additional information with a police officer. There is some debate in the legal community about how broad this section can be applied. But section 43(1)(g) says that you can share information with somebody who is authorized by a subpoena or a warrant or an act of Canada, which would include the criminal code, who's engaged in an investigation or inspection, and then there's some other words. So we also rely on that section quite a lot to share information with police. So in this case, somebody is asking, do we have to wait for the subpoena or the warrant to share the information? Now, What they have specifically asked is, can we give the specific names of our staff to the police? I don't think that's personal health information per se. You've already given the initials. You've already given the record that says a physician with initials KD, a nurse with initials AM, a social worker with the initials GD. So you've already released the actual personal health information. This is just clarification as to who provided it. I mean, that is an aspect of personal health information, but given that you already had the patient's consent to release that information, I don't see that you need to wait for a warrant to share those names. Now, one of the things you might want to do is consult with your human resource department. That you may have an organizational policy about how you release names of your staff to external parties, but I wouldn't worry about that here. So I also, however, want you to think about, sometimes we use initials in records because we are concerned for the safety of our staff. So sometimes we don't release on request the names if to do so could put our staff in harm's way. That's going to be very rare, but we're talking about a very serious situation here of allegations of sexual assault. So it's just something to think about. Okay, so we're nearing the end of our time today. So if you want to squeeze in one more question, please put it in your question box. So we have here another question, and it was, we had a request from a legal office in the United States requesting all medical records and the complete billing records of a patient of ours. So aren't the billing records the property of the physician? So one of the things, again, that you want to think about is, I said the word physician. So every time I say the word physician, I remind you as a privacy officer, sometimes you are acting on behalf of the physicians. Great. Then you just talk to the physician as to what he or she wants. However, if your organization has affiliated physicians who are not your employees, you should always remind them to get CMPA, the Canadian Medical Protective Association, advice. The record request here came with a patient signature. So the patient wants a copy of her records and wants them sent out of country. Is that a problem? No, you can send the records out of country. It is with the patient's consent. But really at the heart of this matter is who owns the administrative records for a patient. And maybe in this case, the patient is having to apply for insurance, like reimbursement, and needs that information in order to be reimbursed. So the details of this kind of case are really going to help guide you. So the patient owns the health record. The physician owns the billing records, but there may be health information in those billing records to which the patient is entitled. It may not be that they are entitled to know how much the physician received in payment or reimbursement for the service, and so it might be that you have to redact those records. So that would be some of my advice, is that it's possible you can redact information from the records that is not health information. And there are lots of decisions that the Privacy Commissioner has issued about redacting information from records. And the other thing is, in these kinds of cases, it's sometimes helpful just to ask, why do you need this? Because it may be that a different kind of record actually will fulfill the purpose. Like, oh, we just need to have a list of all the times that our client came to see you. Well, we don't need billing records in order to be able to provide that. Maybe we could do a summary or something. So I always tend to ask why somebody wants to have access to that record. Okay, so I am so happy that you joined today and that you made time in your schedule. The next Ask Me Anything webinar is going to be September 13th, which happens to be my birthday. And we're going to do another one. So it's pretty much going to be every month. I'm going to have an Ask Me Anything webinar, and you can come on, and there will be a little part at the beginning that gets you an update or a specific hot topic in privacy, and then you can ask me anything you like. And there is, so stay tuned. I will send you the link to the Privacy Officer video series. And again, I invite you to come and join me for any of the courses that I offer. It's so much fun to work with you and be with you, and it's one of my life's passions, is sharing what I know about privacy with people who are caring and committed to really influencing the privacy culture in your organization. So thank you for participating today, and I will see you soon.